Laryngeal stenosis, which probably isn't directly related to like emergency airway stuff, but maybe some of this will give everyone a better understanding for when we're dealing with these kids that we're operating on, that we are concerned about. Instances where when the trach comes out, you might not want to try to intubate the patient for your emergency airways. In the as someone who's sat through like 30 years of ENT M&Ms, we still, about every 5 years, there's a case presentation of a patient who has a trach problem who's maybe had a laryngectomy, and they talk about efforts to intubate the patient orally and why that isn't successful. So anyway, this is a little bit of a offshoot. So what do I press to?
The arrow, right arrow.
Right arrow. Okay, that was a cute little animation there. So laryngeal stenosis, two forms. It can be congenital or acquired. We won't spend a lot of time on the congenital. That's extremely rare, and usually a problem with malformed cricoid cartilage and vocal web. We'll mainly talk about acquired here with intubation traumas. That's the most common, and we won't go over things like laryngeal malacia or papillomas and others. So quickly, here's a couple of laryngeal stenoses. There's a congenital web there and a congenital subglottic stenosis. And the odd thing is that that one on the right there, baby just has that little pinhole airway, and a lot of times in neonates and newborns, they won't really be in that much distress. I mean, it's just kind of shocking how small the airway can be, and it's not immediately obvious that they have a problem, and they're moving so little air that you may not even hear any stridor. But you do need to think about that. But much more common is intubation trauma, and we'll talk a little bit about how it happens. So the patient there on has had an endotracheal tube in place, and you can see there's a lot of changes in the larynx that don't look healthy. And so in the acute phase, we can get predictable patterns of injury, but it can be very unpredictable in occurrence. It's really hard to know which kid is going to have a problem with intubation trauma and which isn't. But the big risk factor is having a tube in there that is maybe too big for the airway, that causes essentially a laryngeal bed sore in there. And as we know, bed sores are never events, except in the airway. And other things that we think of as poor perfusion states and congenital heart disease and hypoxia and so forth. And then these acute injuries will then evolve into forms of chronic stenosis. And then occasionally we'll see what I call late stenosis, which is the subglottic cyst, and we'll go over that. So here are examples of fresh laryngeal trauma, and if you kind of remember these three things, then when I pimp my residents in front of you, you can like jump in with the answer and look smarter than our residents. But there's really just kind of three things that we commonly look for. One is the tongues of granulation tissue, which are these kind of heaped up granulation tissue that forms on what we call this is the vocal process. So membranous cord here, arytenoid back here, so cartilage here. The tube goes through there, rubs against the cartilage, and granulation tissue will form up here, and sometimes it'll form kind of like a complete panis, so kind of a complete horseshoe of this really nasty looking granulation tissue. And then underneath it, you usually see bare cartilage. So we get on the sides, we get these ulcerated troughs running through there, and then down below there is the subglottic region. So just be clear with the airway. Supraglottic airway, airway above the cords. Glottic airway is the airway at the cords, and subglottic is the airway below the cords. And they all have different kinds of stenoses that are managed differently. So not everything is subglottic stenosis, which seems to be the kind of the phrase that is most commonly used. So with acute trauma, and then typically we say, well, we can't get this baby extubated, but the lungs are great, and we always kind of snicker, yeah, right, the lungs are great. But anyway, what we recommend first is that you reintubate with a smaller tube, try some steroids, and then attempt extubation after a few days. And then if that doesn't work, we usually have a look. And if we see granulation tissue, like we have up here, we may try to clear those out with a laser, and if that fails, then we may consider one of our procedures that we'll go over in a bit. So the one on top there, these are actually the tongues of granulation tissue here. And then what's this called here? That ulcerated trough, right? And then down below there will be this subglottic ulcers. And so we've kind of trimmed away some of this stuff. This is actually prolapse of the ventricular mucosa, and took those down with the laser. This almost never works, but it happened to in this case. And this one had a really weird one. It's just this big giant polyp formed on top of the cord and just fell in there, and that's really rare. But when you see that, and you fix it, you can feel like a big hero. So acute injury will then go to chronic injury. So the tongues of granulation tissue go to fibrous nodules. The ulcerated troughs go to healed furrows, which are these little notches in the arytenoids. That's very common after chronic intubation. And then you can also get cricoarytenoid ankylosis. So the cricoid, the arytenoid cartilage gets fused to the cricoid cartilage, so it looks like vocal cord paralysis, but it's actually a form of kind of traumatic arthritis, very difficult to deal with. This isn't a good example of it, but you can get interarytenoid fibrosis, so that's scarring between the arytenoids that keep them from coming apart. So this is what we see at the level of the glottis. You notice I haven't mentioned subglottic stenosis yet. So here are really large furrows there. That would be a big example. That would be an interarytenoid web where those tongues of granulation tissue, as they heal up, have fused together. And that usually happens that's very rare, but when it does happen, it's usually in the setting of a trach, because then the cords don't have to move. And then there's interarytenoid fibrosis back there, and also probably cricoarytenoid ankylosis. So that's glottic, and then at the subglottic level, you can get narrowing, which can be nice and clean and concentric like this. Usually it's just this big swollen mass, and the airway just kind of tapers down to nothing. If I see this, I salivate because I can fix that. If it's just this big swollen stuff, we call that the hot larynx. That's a lot tougher to deal with. So we have a way of, let's say, most of those subglottic ulcerations, sometimes when we look at a larynx acutely and we see horrible injury, we don't know what's going to happen. A lot of them just heal up fine. And everyone gets worried, but a lot of them do fine. But some of them will progress to stenosis, and then there's this staging system, grade 1 through 4, that we use to grade the severity. And we have this kind of system for the patient's size and age and what size endotracheal tube we can put in there and get an air leak around in kind of the range of 20 centimeters of water. And then depending on that, that's how we figure out what grade stenosis we have, so we can kind of keep track of how things are going. And I talk about this late thing, which is these subglottic cysts. Sometimes the baby will survive the initial period of chronic lung disease, a newborn, and then they get extubated, and they're kind of pooping along, and their airway's making a little noise, and they need a lot of bronchodilators, and maybe everyone's saying, probably got some tracheal malacia and so forth, and then 2 or 3 months go by, and then all of a sudden it's like they fall off the table. And what's been happening is you get these little mucus cysts that expand, so there's kind of a single one over there and multiple ones. So these are these slowly enlarging retention cysts. So think of these. I was asked to review a case medical legal of just this tragic thing where this mom had horrible gestational lupus, and then she finally, after 7 tries, got a baby that got big enough that they could deliver it, and then she had a hysterectomy right afterwards, and then the baby died from one of these, and it would have been very easy to avoid. So these things slowly enlarging, only seem to follow neonatal intubations. I've never seen one after, you know, a 1-year-old, 8-month-old intubated. Never, only neonatal intubations. They're very rare, but may come up only after just a couple days of intubation. Just 2 or 3 days even has been the shortest one that we've seen. And usually there's kind of a stridor-free interval, and then these things enlarge, and they're easily managed. Boom, cured with the laser. So now going on to kind of the chronic, more severe stenoses are worse. Okay, so we know that. So for subglottic stenosis, some of them we can treat endoscopically, some require open surgery. So here's one up above, a nice thin web that we've managed opening up with a laser, doing little flaps and looking really cute. I probably could have just popped it and it would have done the same thing. And this you may not appreciate that, you won't appreciate it, but this is actually really impressive. This baby just had a little pinhole opening, and we'd planned a big big procedure and everything. But we'll take a look first, do laser, and then the dad said, you know, the kid's kind of starting to talk now. So we brought him back, and instead of doing the big procedure, we lasered a little more, and over 4 operations gave him a normal airway. They don't all do that, but they do. Some do. But many we have to do open laryngeal surgery. And so we have the anterior cricoid split and anterior cricoid split with cartilage graft, which we use in the acute setting in neonates usually. And then anterior and posterior cricoid split and rib graft, which we refer to as kind of laryngotracheal reconstruction. And we can do this either single stage, so that's a patient where we don't do we doesn't have a trach, and we do it around an endotracheal tube. And at the time period after we do the operation, leave them intubated for, you know, usually, hopefully until they get a big air leak, which may occur 5 to 7 days out. Then we extubate, and hopefully the miracle happens and they breathe. Or we can do the more relaxed version, which is where we put a trach tube in and let things heal up, and then have a more controlled decannulation. Then the other option is a partial cricotracheal resection, which also can be done kind of around an endotracheal tube and extubate at the end of a healing period, or we can put in a low trach. And I'll just kind of briefly go over what these are. So the anterior cricoid split is we just make a simple incision zip in the cricoid, and this is usually in a neonate that fails extubation and slot because things are swollen. We think by slitting open the cricoid, that takes the pressure off, allows the mucosa to heal, and then we wait till there's an air leak, and this heals up, and extubate the patient. What's weird is how when I started out, this was like 80-90% successful, and now it almost never works. And I think it's because the neonatologists have gotten better at keeping the easy kids from having this problem, and it's only the real sick kids that end up having it. So I think there's kind of, that's my personal theory. No one's proven that, but it's really weird how this just doesn't seem to work anymore in the acute setting. So then, for milder stenoses or that are chronic or in acute phase, we'll do an anterior cricoid split and put a little chip of cartilage in there, which we usually take rib, but you can also take the top of the thyroid cartilage. And again, we'll leave them intubated afterwards, and over that time period, we're hopeful that there's healing, and ideally the swelling will go down. There'll be a big air leak. You'll start yelling at us because we can't ventilate the patient anymore because there's too big of an air leak. And we say, great, let's get the tube out. And the risk with this procedure, among the obvious ones of accidental extubation and so forth, is also that after they extubate, sometimes this cartilage will fall in the airway, and we have had some near misses. We had a kid who was discharged after having this procedure and was in the cafeteria getting a last meal before they were heading home, and the graft was kind of rotten and fell into the airway, and the kid obstructed and had to be intubated urgently. So that is always a concern, but a rare complication. And then this is supposed to represent a posterior rib graft, so we can split the front of the cricoid, put a graft there, or we can split both and put a graft in the back front and back, and that makes the airway even bigger. And the graft in the back also helps if you have glottic stenosis because it goes up higher. So we can splay apart those arytenoids and stick that graft up there. So for glottic stenosis, you pretty much always need a posterior graft as well. Post-op care is similar. And then this is the partial cricotracheal resection kind of a schema where when the airway is so bad that the cricoid may be damaged, turned to mush, and there may be tracheal involvement as well, we'll actually just do essentially a segmental resection and then leave the back part of the cricoid cartilage there then go and resect trachea. Frequently there may have been a trach tube there, and we usually take out the old stoma when we do this. And then we have this gaping, sometimes just, we're just taking out this much, and you do the trachea, and boing, it falls down into the chest, and you go, oh, this is going to be fun. But we pull it up and sew it up. Sometimes then we'll put another trach in further down below that if we're really nervous, and let things heal up, and that's some technical stuff that you don't need to know about. So here's a kid with a complete stenosis, and so what you're looking at here, we left a little tiny bit of the top of the cricoid there, so we took out the bottom half, and then here's the bottom of the trachea, and we're pull those together, and there's a bit of a, so here now we pull it, there's a bit of a size mismatch here. This was bigger than this, so we left that open and then just sewed a little piece of cartilage on there, and we have some before and after. One thing with this is if they arch their neck, it'll put stretch on it, and sometimes you can have a catastrophic separation, or you can just have a slow separation over time, and both are bad. So we like to keep the neck down like this if we can. So one strategy has been to sew the chin down to the sternum, and I heard a gasp in the audience, and that was appropriate because that's horrible. And they end up with these big, huge scars too from those stitches. Like the two worst places in the body to put a big, nasty stitch. And so we will sometimes have orthotics make a little thing so that they can't arch their little neck. So for single stage repairs, we usually intubate for 5 to as long as 14 days. And what we want is a slightly mobile patient who won't self-extubate. So avoid prolonged neuroma, not too much sedation, and not my clever use of irony there. The last one, we actually had like this teenager, I don't know if anyone was in there, and we did a nasal intubation, and we woke him up, and that's supposedly what they do in Cincinnati, and the kid did great until he kind of partway coughed his tube out, and then couldn't breathe, and then he just pulled it, apparently yanked it out as he was getting a lot of attention, and did fine. So we're always worried about edema, and also particularly for nasal tubes, watch for alar necrosis. Also watch for occipital necrosis, and because a lot of times they're so worried about having a move that they're just sitting on the back of their heads. And we usually treat for reflux for no good reason, and then Decadron, which Dr. Haberkern calls vitamin C. Kathy C likes to use that a lot in her airway cases. So, and then we have kind of a new thing, and I'm just going to toot my horn just for a second here. Is that I developed this procedure for endoscopic posterior graft placement. So instead of having to open the neck up and do everything, you can actually pop the graft in endoscopically, and so that is another approach, and we use that for posterior glottic stenosis. There I've divided the cricoid cartilage in the back endoscopically. So these are the vocal cords up there. Okay, and then this is the cut edge of the cricoid cartilage split open, and that's the kind of the wall between the esophagus and the cricoid in the back, which has not been broached. The mucosa has not been broached, and we put a little chip of cartilage in there, and that's kind of it's kind of big there, but and that will fit in there. We don't have a video, but you can see kind of before and after down there. So, and when the gods are smiling on us, we get this. So, all right. So I tried to be fast because we're behind. So, any questions about all this?
I'm wondering, if it is like a frontal resection, how on earth are we oxygenating the patient?
How are you what?
Oxygenating.
Oh, so we'll have a tube in with that picture. So we have a tube that we slide in and out during the case, and so that picture was taken with the tube out, and we often have like a small cuff tube that we slide down, and we can kind of work around it. Swing it over one side, the other side. It is an annoyance for us to have to be oxygenating the patient during the case. But we work with it, because we're that kind of people. That's a good question.
Does it affect the vocal cords and speech?
Well, so first off, these kids have horrible. What really affects the speech is the quality of the voice is just the injury itself. So these vocal cords. If you want to see something cool, do a YouTube search on video stroboscopy where they slow down the ripples coming up the underside. It's just this beautiful, very delicate thing, and anything that disrupts the lamina propria reduces that mucosal wave, and so it's almost like we can't make the voice worse. There's nothing we will do that's going to make the voice worse, because it's usually horrible to begin with. But what was really that one case of the partial cricotracheal resection that I showed was a kid that was I think it was like an Ethiopian baby back. I think it was Ethiopia. Anyway, somewhere from that East Africa, and it was during the Civil War, and someone, one faction came through, killed everyone in the village, slit this was a newborn baby's throat, and left it for dead. And then the aid crew came in, and Red Cross or something found this baby. They managed to do emergency trach and formed this complete stenosis there, and the baby bounced around. It finally came to me when the baby was like 3 or 4 years old, and I did that resection and extubated the patient, and she was talking within like 5 days. It was the most astonishing thing. This baby had never practiced using the vocal cords, anything like that. And because it wasn't the standard intubation injury, and the cords themselves hadn't been disturbed, the patient just had this angelic voice. It was kind of miraculous.
That's why we work at Children's Hospital. We're at home, caring cure.
Thanks.